I am Margaret Williams, Professor Margaret Williams. I work at Nelson Mandela University in Port Elizabeth. I am a primary healthcare specialist. I teach the advanced primary healthcare degree course at Nelson Mandela University, which I developed and which my students are really challenged to up their game in the primary healthcare clinics. I keep telling my students, your patient comes to you, you are the first line of care. And that first line of care is the most important, especially when we don't have doctors in the clinics. So the nurses that come through the course at Nelson Mandela University, I like to think, are ready to face the patients in the primary healthcare clinic with renewed enthusiasm, knowledge, and capacity to do problem solving and diagnostics. Chronic renal disease or chronic kidney disease is not something we speak about very often. The statistics are incredibly high. We have so many people in this country and sub-Saharan Africa and most developing countries, in fact, with chronic renal disease or kidney disease of some form or another. And it's not an area that's had a lot of press or people going, gee, I wonder if that person with a chronic disease could have a chronic kidney disease brewing or starting up. And the reason for that is because it's normally symptom-free until the problem starts. And once the symptoms are there, the patient is in a very bad state and probably quite a high grade of chronic kidney disease. The kidneys are quite little soldiers. They keep going for a very long time. But once it doesn't, we are going to know about it with that patient starting with symptoms. So we want to stop it before the patient starts with the symptoms. Which of your patients in a primary healthcare clinic could possibly have a chronic kidney disease? Well, your chronic non-communicable diseases, so your hypertensions, your diabetes, those are your key areas that you need to be looking at because those are the patients that are going to come in with a chronic kidney disease. You could also have those with infectious diseases that you need to look at. Your HIV patients who are on ARTs. Your HIV patients before going on to ARTs or if they've had HIV for quite a long time are candidates for chronic kidney disease. But so are your patients who are on long-term ARTs because remember, those are nephrotoxic. Any of your patients who have been on anti-inflammatories for a very, very long time because you know they always have this chronic rheumatic pain, which is not always sent to a pain clinic or an arthritis clinic. So maybe we've just been feeding them Brufen, in which case we might want to check when that patient's getting older how their kidney function is doing so that we can see if they are candidates or if there is any problem with their renal functioning. So how do you check your patient? Well, a simple blood test. Creatinine clearance can be done. That's a 24-hour test. We wouldn't normally do that. I think that would be hospital-based. But you can do a serum creatinine just to get us an indication. There are special tests that can be done which would be ordered by a physician or the doctor. But if you think there's anything wrong, you can at least do the U&E, the urea and creatinine. And also a simple dipstick test, checking for protein. Has your patient got protein in the urine? And maybe nothing else. So they haven't got nitrates, they don't have blood. So you're not suspecting that there's an infection, but there is a change in the protein. Now, if that patient has got other risk factors like I've just mentioned, you will want to send that patient for further investigation because that can be a precursor to chronic kidney disease. It's that easy.